AP Tamil Nadu State Chapter, Dr. Rajendran sir, to deliver his welcome address.
Thank you, Dr. Nirmala, and most respected our scientific advisor, Dr. Singarvel sir, and respected President 2024, Dr. Balashankar, Dr. Somasundaram, President-elect, and Vice President, Dr. Gopal Subramaniam, and our Secretary, Dr. Narmada, Treasurer, Dr. Rajkumar, and our scientific advisor is, I think, Singarvel is there, no?
Yes, sir.
Yes, sir.
Sir?
Yes, sir. Yes.
Yeah.
Sir is here, sir.
Our academic coordinator, Dr. Tirumurugan, on behalf of IAPTNSA, I welcome one and all. It is a great pleasure and a privilege to be here, and as a president, no? And almost we are having 900 PG teaching program as well as CME we are having in IAPTNSA YouTube channel. And it is I request the scientific advisor, sir. Dr. Singarvel sir?
Maybe he just left,
Okay,
sir.
sorry,
Maybe
wait,
it's
wait.
internet connectivity.
Okay,
Yeah.
Convener, so today's PG teaching program, Dr. Kritika, on behalf of IAPTNC, really appreciate. And I welcome today's faculties, Dr. Sridevi and as well as Dr. Vinod. So both are eminent teachers. On behalf of IAPTNC, I welcome one and all. And I welcome today's teaching program from Thoothukudi Medical College. And our my friend as well as my batchmate, Dr. Arnachalam is there. And on behalf of IAPTNSA, welcome Dr. Arnachalam. And I welcome Dr. Naresh and learners from Thoothukudi Medical College. Today is a very important day. So that's why I called Dr. Singarvel sir. And because order one day, one drug, we are we are 200th order we are going to publish in. Is really thankful to our Singarvel sir for his guidance and advising and to make this possible. And every day, I think midnight we are putting order, and really it's great going. And all over India, it is reached, and it's all because of all team effort, particularly order team, and who has helped us. And particularly thank Dr. Tirumurugan and Dr. Balaji and entire team to make this possible. And these few words, I request our scientific advisor, Dr. Singarvel sir, to tell few words.
Thank you, our President Rajendran sir. Good evening to all. It is really a very memorable day that our visionary president and Tirumurugan, Namoda, Rajkumar, everybody planned under the guidance of our Balaji and the entire team of our scientific team who planned this word, which was a very successful, and it gives me a very good input wherever I travel all over India. I am proud that our president, whatever he thinks, and it is being well executed. I am very proud that I am part of this scientific team. Thank you, sir. And very happy to see we have completed the 200 days. How it runs, we could not believe it. So coming back to our today's program under the leadership of our team, Kritika is doing extremely well, and Leonard Srinivasan sir, Zareen from Udaipur has come, and all our teachers are here. I'm happy to be part of it. I don't want to take much time except to congratulating both the lead concert discussions and the PGs of Thoothukudi Medical College. Definitely, it will be a very happy learning, not only to postgraduates, and also because Vinod and others are very good in their academic, which I know. Surely it will be beneficial to all the viewers through Zoom as well as in YouTube. Happy learning to all. Thank you, sir, for giving me this wonderful opportunity. Over to you, sir.
Yeah. Thank you, Singarvel sir, for your kind felicitations, and congratulations to the ODOT team for the 200th edition of the ODOT today. And it was really nice that today we could inaugurate, share this very great news in the postgraduate program. Sorry, I think. Thank you, Singarvel sir, for your words and of appreciation. And thank you, ODOT team, for your tremendous work and of making 200 issue possible. And we know that's one of the greatest success of our team all across India. Thank you so much for Professor Rajendran sir and Dr. Tirumurugan sir and Dr. Balaji for making this possible. Today is a very interesting session. Dr. Sridevi, one of the meticulous teacher whom I've really worked with, and Dr. Vinod are going to join with Thoothukudi Medical College team. Very wonderful session, anemia with splenomegaly. Our postgraduate case, this is one of the cases which we are very commonly know that we need to get it in our exams and also know that it can trick us in any way. So, Kritika, I know you will have an interesting session. Handing over to you for yet another interesting session in the presence of all the teachers. Thank you so much for organizing the same.
With permission, Narmada, one word. The interesting part is, even in the day of conference, our President Rajendran sir, in spite of his hectic schedule, and Tirumurugan and all that,
he released
release the WODA even the later. That is the real thing which the all busy schedule, they are able to release. Hats off to you. Thank you, sir.
Before going to case now, I want Dr. Gopal Subramanian few words. Gopal is there. And,
Thank you, sir. Thank you, President, sir, Secretary Narmada and Rajkumar, Scientific Advisor Singaravelu, sir, and my teacher Srinivasan, sir, Academic Coordinator Thiru, Sridevi Madam, and Vinod. Thanks to Kritika for this wonderful postgraduate teaching. Has been a great hit among postgraduates. Last time, as I said, even my son is attending this program every now and then. So it has been a very good teaching platform for the postgraduates. I wish the program a grand success. Thank you.
thank you. And before going to Dr. Tirumurugan, a few words about water. Sir.
Thank you, sir. At the outset, I'd really like to thank the incredible support from
Tirumurugan, voice is not hearing. Hello.
Thiru, voice breakout.
It's an elaborate program this year, and which has been executed to perfection thanks to all their support. Of course, we also had incredible support from Dr. Narmada, Dr. Gopal Subramanian, Dr. Rajkumar, and Dr. Somasundaram, Dr. Balashankar, and the Joint Secretaries, Dr. Sridevi, Dr. Jayavardhana, and Dr. Balaji. I must really thank for the motivation. See, you can do it, but to get it on time, there are two people who are always on behind my back. One is, of course, our president, but the other one is always Dr. Singaravelu sir, who has really made it a point to advise us, to give us valuable inputs to improve these issues as much as possible. So today, we cannot even recognize what, the format is so good now when compared to what we started with. And so I really thank Dr. Singaravelu sir for the incredible advices we have given and the simple informations which have modified it. And we are very happy to say that two things are going to happen with this. So one is there is going to be a compilation of all these issues, sections which will be released very shortly from the next week onwards. So everybody who missed out on the individual issues will be able to get a hands-on of the individual sections. And apart from that, we are also hoping to release it as a book, which will be useful for all the pediatricians as a outpatient, as a clinical bedside record. Very shortly in the early next year, once we complete all our issues. So I once again thank Dr. Singaravelu sir for his wonderful support, and also the rest of my core team and office bearers of IAP TNSC for being constantly here and encouraging us to make sure that we get it on time. So thank you very much.
Rajendran sir, can we proceed with the academic program?
Please.
Yeah. Thank you so much. So, Kritika, over to you for yet another interesting session on anemia with hepatosplenomegaly. It's going to be a very exciting session. Over to you and to the experts who are here to guide you through the program.
Thank you, ma'am. Thank you, ma'am. Respected Rajendran sir, Balashankar sir, Somasundaram sir, Gopal sir, dear Narmada ma'am, respected Rajkumar sir, Tirumurugan sir, Professor Srinivasan sir, Devendra sir, and all dignitaries and students. Good evening, and it is so happy for me to welcome you all to the 9th Postgraduate Masterclass today. The most important topic, anemia with hepatosplenomegaly, a must-to-know topic for all the postgraduates. To learn us today are from Thoothukudi Medical College under the able mentorship of Dr. Naresh, Professor of Pediatrics from Government Thoothukudi Medical College. And we do have with us two learners today, Dr. Ramya Shekhar and Dr. Rajesh Saraswati, who will be presenting the case. And the faculties are fantastic faculties we do have today. Professor Sridevi Madam from ICH and Dr. Vinod Gunashekaran, who is a consultant pediatric hemato-oncologist from Ma Kaveri Hospital, Trichy. And I'm looking forward to the interesting session as you all of you. And Ramya, can you share the screen, ma? Are you here? Ramya? Rajesh Saraswati? Rajesh Saraswati, Ramya? Anand sir? Sir, Arunachalam sir? Hello sir?
Hello.
Hello?
Yeah, she's sharing.
Sir, yes, sir.
Hello.
Hello, Rajesh Saraswati?
Ma, unmute பண்ணுமா?
Yes, ma'am, she's sharing the screen.
Yes, sir. Okay, Anand sir. Is Ramya available, sir? She told me that her connection is not stable. Hello?
Dr. Saraswati, you can stop your video. I'll stop your video so that it will be much better see.
Your screen is visible, ma?
The slides visible, ma'am?
Now it is visible, ma. I think you have to go there and click. The one on the down left. Just go and click, then I think it will move.
So you need to turn it
Or
to
you
the
go to
board
the
and- because I think-
slideshow. You go to the slideshow,
Slideshow.
ma.
It's
You
visible,
go to the
ma'am?
slideshow.
Right at the top, no?
Yes, visible, ma. Visible and you're audible. You go to the slideshow, da.
Okay.
Yes. But can you move your slides, ma?
Shall I start, ma'am?
Yes, ma'am.
Can you turn it around? I mean, you need to go to the presentation mode.
No,
Go to
I think,
slideshow.
yeah, you have not gone to the slideshow. You have not gone to the slideshow. Now your slides are not visible, ma.
Dr. Ramya, can you share your slides? Or can you
Yes,
share the
yes,
slides?
sir. I will share the
I'm
screen.
Miss Marish.
Is your connection stable now, Ramya?
Yes, ma'am. Sorry for the
Yes, you
inconvenience.
do it from your laptop. No issues, ma. You do it from your laptop. That will be better, I think.
Yes, ma'am.
Okay, ma. Yes, Ramya,
Ma'am,
clear.
is screen
Yes, ma.
visible?
Yes,
Yeah,
ma. You
yeah,
can
yeah.
go to the slideshow, da.
Ma'am, can I start the presentation?
Yes, ma. Yes, ma. Please. Yes, ma. Yes.
No, you haven't gone into the
You have to.
slideshow.
Yeah. You have to go to the slideshow. You go to the slideshow here.
Make it full slide.
So, no, you have clicked the icons there. You come out of it, click outside. You are clicking the text box, right? To come out of it, click outside and go to the slideshow.
Okay,
To come
ma'am.
out of it. Yeah.
No.
No. We are not seeing your slides, ma.
Now,
You have started to screen share, but your
slides
screen
are
is still not visible. Yes,
visible,
yes.
ma'am.
Yeah. Your slides are visible, ma. You go to the slideshow.
Now slides are visible.
Yes, slides are visible, but
Your
not
voice
in
is
the
breaking.
full screen mode. Go to
Yeah.
the full screen here.
Yeah. You have to go to the full
The
screen
right
mode.
side
You have to
bottom,
click
no?
the
Right
slideshow.
bottom. No.
Or I think we can start presenting with this actually.
This
Because
is also
Now,
visible. Yeah.
ma'am.
You can start
Your voice is
presenting
breaking,
then.
Ramya. Yeah. You can switch off your camera and start presenting.
now
so
the
that I
screen
think
is-
your voice won't break. Yes, ma. Visible. You start presenting. You go to the next slide.
Okay, ma'am. Okay, ma'am. I'm going to start the presentation on anemia with hepatosplenomegaly. Master X, 2 years old male child.
can
Second
you
one
move
out of
slide please? Can you just move the slide please? 2 seconds.
Your slides are not moving, ma. You go and click.
ma'am now.
Yeah.
Yes. Your slides are moving.
Okay, ma'am.
Yeah. Okay.
Master X, 2 years old male child, second born out of non-consanguineous marriage, coming from Koilpatnam, Thoothukudi, who's brought by his mother, whose reliability is good, came with the chief complaints of at the 6 months of age, child presented with the complaints of fever for 7 days, complaints of cough and cold for 7 days, complaints of difficulty in breathing for 2 days, complaints of progressive abdominal distension for 1 week, and complaints of progressive pallor and easy fatigability. Now, child came for a blood transfusion. History of presenting illness. Child was apparently normal till 6 months of life. Then he gradually developed history of fever for 7 days, which is acute in onset, intermittent in nature, high grade fever, not associated with chills and rigor, relieved with medication. History of cough and cold for 1 week, acute in onset, wet cough, no diurnal or postural variation, no post-stressive vomiting. History of difficulty in breathing for 2 days, which is acute in onset and associated with indrawing of chest. History of abdominal distension present for 1 week, which is insidious in onset, predominantly upper abdominal distension, gradually progressive and not associated with abdominal pain or constipation. No history of refusal of feeds. History of refusal of feeds for 2 days. History of irritability in the form of incessant cry for 2 days. History of pallor, which is increasing and progressively. History of easy fatigability present. History of failure to try present. No history of pica. No history of jaundice. No history of fever with rash. No history of bone pain, recurrent infection, or bleeding from mouth. No history of arthralgia, ulcers in leg, and painful erection of penis. No history of seizures or difficulty in using limbs. And no history of passing frothy or bulky, foul-smelling stools. No history of any dysmorphic faces. No history of swelling of limbs. No
Hello, Ramya.
history of
Ramya, your voice is breaking, ma. Hello, Ramya. Hello, Ramya. Hello, Ramya.
High grade fever.
Raja Saraswati, do you have the slides, ma? Can you share?
Yes, ma'am, I'm having.
Can you share and start presenting?
Okay.
Yes, please. Please do. Please do.
Shall I start from the
Yes,
first
yes,
one?
yes. You start from that what she left, that no history of dysmorphic faces and all
Ah.
those things. And go there and start presenting. Ma. Continue.
Okay.
She had completed before that. Next one. Yes, ma.
Now the
No history of
child,
swell.
for this, the child was initially treated on OPD basis in a nearby private hospital. No improvement seen, worsening of symptoms present. So the child was taken to private hospital in Tirunelveli. The child was admitted there, and after the examination, mother was told about the child having a severe pallor, swelling of abdominal organs. CBC was found to be low, hence blood transfusion was done. Then the child was investigated. Finally, one blood test showed evidence of hematological disease, which warrants regular transfusion. And parents were tested and found to have a similar disease. Then the child was taken to TKMCH for further management. Now the child is on regular blood transfusion. Past history, no history of a congenital heart disease, seizure disorder, hypothyroidism, type 1 diabetes in the child, no history of transfusion reaction, no history of previous surgeries. Antenatal history, mother attained a menarche at 14 years of age. She had regular cycles, normal blood flow. Age of mother at marriage is 18 years. Age of the mother at first conception is 20 years. And the first child is 11 years old, a female child, alive and healthy. And the second child is the present pregnancy. Pregnancy was confirmed by ultrasound at 45 days at a private hospital. She was registered and immunized at Kailpatnam GH. Last menstrual period was 9/9/2022. EDD was 16/6/2023. Mother was on regular visits at both the private and the government hospital. Maternal blood group was O positive. Spouse blood group was O positive, and pre-pregnancy weight is 53 kg. First trimester, no history of preconceptional folic acid intake, no history of excessive vomiting, no history of fever with rash with a periauricular swelling, post swelling, no history of chronic maternal illness like chronic hypertension, hypothyroidism, diabetes, rheumatic heart disease, seizure disorder, or tuberculosis. No history of bleeding or draining TB, no history of drug intake, no history of radiation exposure. TD first dose was given at the time of conception. Dating scan was done at the 3 months of gestational age. Quickening was felt at 5th month of gestation. Iron, folic acid, and calcium tablets were taken regularly. Second dose of TD was given at 4th month. No history of vomiting, no history of bleeding or draining TB. Mother was diagnosed with gestational diabetes mellitus by oral glucose tolerance test, which was done at 7 weeks of gestational age. Mother was advised to follow the meal plan. No history suggestive of gestational hypertension and hypothyroidism. History of anemia present, which was found on regular checkup. HB found to be low, hence 4 doses of iron sucrose injection were given. No burning situation present, for which mother consulted a private hospital, advised adequate hydration. Urine test was found to be normal. No oral medications prescribed. Anomaly scan was done at 5 months, which was said to be normal. Third trimester, mother continued to perceive the fetal movements. Gestational diabetes mellitus was present, which was diagnosed at the second trimester and mother was on a meal plan. No history of gestational hypertension, hypothyroidism. No history of burning micturition. No history of lower abdominal pain. No history of bleeding or draining TB. No history of pain abdomen. No history of blood transfusion or trauma. Growth scan was done at 7 months of gestational age, which was said to be normal. Weight at last trimester is 65 kg. Weight gain was adequate, which is about 12 kg. Total antenatal visits, 10 visits. Natal history On the day of expected date of delivery, that is 16/6/2023, mother had complaints of lower abdominal pain. So taken to a private hospital, labor progressed naturally, and she delivered a alive male baby of birth weight 3.5 kg, cried at birth. Breastfeeding was initiated immediately after birth. Meconium was passed within 24 hours. Urine passed within 48 hours. Postnatal history: no history of NICU admission, no history of neonatal jaundice, neonatal seizures, or bleeding in the child. Developmental history: gross motor, fine motor, and social adaptive milestones were attained appropriate for the age. The child had isolated language delay present. Immunization history: the child was immunized according to national immunization schedule. Last immunization was given at 1.5 years of age with measles rubella booster, DPT, and OPV boosters. Next vaccination is at 5 years of age with the DPT booster. BCG scar noted, no history of adverse events following immunization. Diet history: exclusive breastfeeding was given for 4 months, then started on formula milk. Complementary feeds were started by the end of 6 months. The child's expected weight is 12 kg. His actual calorie intake is 1033 kilocalories as against expected 1100 kilocalories. And the calorie deficit is 67 kilocalories per day. And there is no protein deficit. Family history: no history of similar illness in the family members. No history of recurrent blood transfusion in the family members. No history of abdominal surgery, leg ulcers, jaundice in the family members. No history of unexplained death in the family members. Socio-economic history: it's a nuclear family with 4 members. Father, who is the head of the family, is studied 8th standard, skilled labor. Mother studied 12th standard, is a homemaker, and their per capita family income is 3,750 per month. They live in a pakka house with 4 rooms with a separate kitchen and toilet, cross ventilation and adequate lighting present. They use LPG for cooking. They use RO water after boiling for drinking. Wastes were collected by municipal people. A proper sewage disposal present. No history of rearing pet animals. No history of mosquito breeding sites near the house. According to modified Kuppusamy scale, the family belongs to a lower middle class. Both mother and father were aware about the natural cause of the disease and the need for regular blood transfusion. Contact history: no history of contact with active case of tuberculosis. Summary: 2 years old male child, second born out of non-consanguineous marriage, who is a known case of anemia, came for regular blood transfusion, belongs to lower middle class. At 6 months of age, child presented with complaints of fever and cough, cold for 1 week, associated with difficulty in breathing for 2 days, and complaints of abdominal distension for 1 week with irritability and refusal of feeds for 2 days. History of pallor and easy fatigability present with failure to thrive, for which the child is admitted in private hospital, diagnosed with a transfusion-dependent anemia, and now the child is on regular blood transfusion and oral medication. Compliance is good, and now the child came for regular blood transfusion. With the antenatal history, history of anemia complicating pregnancy, and the mother was given 4 doses of iron sucrose injection. No history of NICU admission, and the child had isolated language developmental delay, and the child is immunized till date. Probable system involved is hematological. Hence, I want to proceed with the abdominal examination.
Good presentation, Ma. Before you proceed to the examination, we'll have some questions. So, Vinod sir, can I start asking some questions?
Yes, ma'am. Please proceed, ma'am.
Yeah. So first of all, you said that this is a 2-year-old boy who's come now for transfusion. He was diagnosed with the transfusion-dependent anemia at 6 months of age. So what happened in between? What about the course of the illness in between? From 6 months to 2 years, till now, how many transfusions he has received? How frequently?
From 6 months of age, he has been receiving the transfusion every 3 to 4 weeks, ma'am.
Okay, so far he's received how many transfusions?
More than 20 transfusions, ma'am.
Okay, so far he's received more than 20 transfusions.
Mm.
So apart from that, is there any other illness during this 1.5 years?
No, ma'am.
Okay, you go from the first slide, I mean from the second slide. Sir, you want to ask anything or with each slide you want to ask?
Yes, ma'am. Actually, in this slide you start, ma'am. I'll interrupt if I have any questions. Yes, I slide with.
So you said this is a boy child. So you have anything, now this is a hematological disorder. Do you have any gender association with any specific hematological disorder?
In G6PD deficiency, it is an X-linked recessive disorder.
Very good. So it is common and which gender?
Male gender.
Okay, very good. So, and this child you said has been receiving transfusion almost once in 3 to 4 weeks.
Yes,
Is there any change in the transfusion requirement or is it the same for the last 1.5 years?
No, there is no change in the transfusion requirement, ma'am. It is the same, ma'am, since 6
Okay.
months.
So if there has been a change, what should you think?
Maybe it may be due to hypersplenism, or it may be due
Very
to
good.
alloimmunization, or any other infection with parvovirus infection.
Very good. So that will, you'll think of all that if there is going to be any change in transfusion requirement. Okay, you go forward. Move the slides forward. Next. Okay. So why did you ask for previous? Yeah. Why did you ask for history of jaundice?
If there any other hemolytic anemia, or in case the transfusion is not adequate, the thalassemic children may have jaundice or any other infection.
Think of hemolytic anemia, you are asking for jaundice. Because jaundice and anemia together, you should think of hemolytic anemia. Why did you ask for history of fever with rash?
Parvovirus infection.
Which
Okay.
causes
Okay. What about this frothy, bulky stools?
Due to malabsorption, the child may have anemia, like disease like the celiac disease, tropical screw and all.
Okay. For etiology of anemia. Okay.
Etiology.
Next. Okay. You said the history of failure to thrive present. What did you exactly mean by that?
Initially, the child did not have any adequate weight gain until 6 months of age.
Okay. Can you objectively tell that what was the birth weight? What was the weight
Birth
at
weight
6
was
months?
3.5 kg, ma'am. At around 6 months, the child's weight was around 5 kg, ma'am.
5 kg. Okay, the child has not even doubled the birth weight.
Yes,
So you're saying it is failure to thrive
Failure to
at
thrive.
that time. But
Yes,
now, if you see, you said 12 kg, no?
yes, ma'am.
2-year-old child, 12 kg seems good enough.
Yes, ma'am.
Okay. Next slide. Next slide. Okay. The child is also on oral medication. From when?
2 months
Only
back, it was started, ma'am.
Okay, 2 months back, the oral medication was started.
Yes,
Till
ma'am.
then, there was no oral medication. It was
No,
only
ma'am.
blood transfusion.
Yes, ma'am.
Okay. What about the decreased urine output?
This was asked for failure signs, ma'am, failure symptoms
Okay.
due to iron overload or anemia.
Okay. Next. 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 You said the mother took iron and folic acid and calcium regularly. How many
Yes.
tablets did she take during the entire pregnancy?
Initially, she was taking one tablet, ma'am.
For how many days? From when to when? Totally during pregnancy, how many tablets she has taken?
Since third month of gestation, she has started taking iron folic acid tablets, ma'am. Initially, she was taking one tablet. Then after diagnosing anemia at fifth month, she was given 2 tablets per day, ma'am. Then iron sucrose injections, 4 doses was also given, ma'am.
Along with that, tablet was also given.
Yes, ma'am.
Okay, a non-anemic mother, how many tablets should she take during normal pregnancy?
OD dosage, ma'am, for
Only
prophylaxis.
1 tablet.
How many tablets during pregnancy totally?
Ma'am, Dr. Ramya is
180.
also available for
1
discussion
tablet.
now, ma'am.
Yeah.
Ramya also has joined.
Yeah, 180. So normal mother should be taken at least
Yes, ma'am.
180 tablets during her pregnancy. Since this mother was anemic, she was given parenteral as well as more dose. Okay.
Yes, ma'am.
And she was only on meal plan for GDM.
Gestational
Okay.
time.
Next. Okay, next. Next, I wanted to see the pedigree chart. Choose changed immediately. Can you show the pedigree chart? Okay, in the neonatal history, if the child had suffered from neonatal jaundice, what all will you think?
Hereditary spherocytosis or
Hello,
RH
ma'am.
incompatibility.
Okay.
Ma'am?
Okay, ABO-RH incompatibility is common. And among the hemolytic anemias, hereditary spherocytosis is the one which presents during neonatal period. Go to the pedigree chart. Yeah. You said there were 2 children, but this pedigree chart shows only 1 child. Where is the other child?
Sorry.
I was wondering, you just changed it very fast. So this is a second born child, no?
Yeah, yes.
Okay. So the other child is missing. Okay. Okay, sir. Over to Vinod, sir.
Thank you, ma'am. Just few questions. Thank you to Dr. Raja Saraswati. The presentation was very nice.
Thank you.
said a child had severe anemia, taken to a hospital and received blood transfusion. So, what would you do before the first blood transfusion? What precaution? What important investigation which you should be sent before transfusion?
Blood grouping, typing.
Okay, so without that, we cannot
BCT.
transfuse. Okay.
Then extended grouping and typing.
So a child with 6 months age, hepatosplenomegaly anemia. So you don't have any diagnosis. You are planning to transfuse because hemoglobin is say 3-4 grams. So what investigation you should send before transfusion? Because after transfusion, the picture will totally change. What is that investigation?
CBC with the peripheral smear, RBC indices.
Okay, so then?
The retic count.
Okay.
Then HPLC, hemoglobin
electrophoresis, we should take before transfusion itself.
Yes, Dr. Ramesh. Before transfusion, we have to do electrophoresis because once you transfuse, the fetal hemoglobin, adult hemoglobin ratio is totally changed. So once you miss that window, then it will be difficult to diagnose after that. So you also said parents had similar disease. So is that the correct term? The parents are having the disease, or it's a better medical term to mention it?
They are carriers.
Yes, because they don't have disease. They are asymptomatic. You can't label them as similar disease. They are told to be carriers of the same disease which the child had. In past history, somewhere you mentioned about the thyroid and type 1 diabetes in a 2-year-old child. Why did you ask that history?
Yes, the child had no symptoms suggestive of hypothyroidism, sir.
So why did you ask for hypothyroidism and type 1 diabetes in this child?
Because of complications due to iron overload, sir.
Okay, when do you expect diabetes in a transfusion-dependent child?
After 10 years.
Okay, well, iron overload should set in and damage the pancreas, thyroid, etc. So it's very young age, but still okay. So you said antenatally, mother received oral iron followed by IV iron. So was there a
Yes,
response to IV iron in regard to hemoglobin?
Yes, sir.
So if there is
She
no
told,
response,
she told there was increase in HB, sir.
so okay, here antenatal mother has hemoglobin of 9, microcytic hypochromic picture. So initially taking oral iron, then took IV iron, but hemoglobin remains 9, similar microcytic picture. Can you explain in this scenario why the mother is not having rise in hemoglobin?
It may be due to the thalassemia carrier state.
Carrier state, the hemoglobin may be slightly low. So all microcytic anemias are not thalassemia or iron deficiency. In such scenario, think of thalassemia carrier state, which helps in prevention of thalassemia birth. Okay, you mentioned about vaccination. In this scenario, which vaccine is very, very important in child with regular transfusion? Which vaccination prevents a particular complication of transfusion?
Hepatitis B vaccine.
Yeah, correct. Hepatitis B is a preventable complication of repeated transfusion. You asked about leg ulcer. In what way it helps in your family history?
In case of sickle cell anemia and thalassemia,
In case of sickle cell anemia,
Non-healing ulcers. Okay, thalassemia intermediate patients can have non-healing ulcers as a complication because of skin hypoxia. Okay. So just last question, name few conditions which can cause repeated blood transfusion since early infancy, say 6 months of age. Name 3 or 4 conditions at least.
Thalassemia major,
Okay.
then bone marrow infiltrative diseases like Fanconi's anemia, congenital dyserythropoietic anemia.
Okay, Fanconi, what age will Fanconi manifest usually, at newborn or later age? Infant or later?
1 to 2 years.
So Fanconi will start manifesting above 5 years usually. So you said, okay, thalassemia, okay, agreed. Congenital dyserythropoietic anemia, agreed. Any other anemia causing repeated blood transfusion? Need not have spleen at all. Forget about liver, spleen. Anemia.
Aplastic anemia.
Okay, again, in aplastic anemia, in less than 1 year, it should be inherited. Okay, inherited bone marrow failure syndrome. So we can use that term. Then, if any condition where only HB is affected, other lineage are normal. Only blood cell production or red cell production is affected in the bone marrow. The rest of the lineages are produced well.
PSN syndrome, sir.
Okay, so that can cause pancytopenia also. Only anemia. Only red cell.
Diamond black fun anemia.
Yes, red cell, pure red cell aplasia. Okay, fine. Okay.
Pure red cell.
Okay, thank you. Proceed with the next thing.
Just one more question. Sir asked you the first question he asked, what will be the investigation you'll do before you transfuse? Imagine you have transfused. Now you need to investigate this child for the etiology. What can be done?
We can do for the parents. If the carrier status in the both parents is found out, along with the clinical findings of the child, we can diagnose, or else we can go for the gene sequencing.
Very good. Either you check the parents or you go for genetic testing in the child. Okay, good. Proceed.
General examination. After getting consent from the mother, the child was examined. Child was alert, active, pallor present, no icterus, no cyanosis, no clubbing, no pedal edema, no generalized lymphadenopathy. Anthropometry. The child's actual weight is 9.9 kg as against expected 12 kg, which lies between 0 and -2 standard deviation, which is normal. Height is 85 centimeter as against 89 centimeter. Expected height is 89 centimeter, which lies between 0 and -2 standard deviation, normal. Head circumference 46 centimeter, between -1 and -2 standard deviation, normal. Mid upper arm circumference 15 centimeter, normal. Weight for height between 0 and -2 standard deviation, normal. Vitals, pulse rate 100 per minute, regular in rhythm, normal volume, no specific character, no radiofemoral or radioradial delay. All peripheral pulses are bilaterally and equally felt. Respiratory rate 30 per minute, regular, abdominothoracic type. Blood pressure is 80/54 millimeter mercury, measured in left upper limb in supine position. Temperature is 98.6 degree Fahrenheit, measured in the axilla. Saturation 98% in room air, measured in the right upper limb. Head to foot examination. Hair black in color, no flag sign. Head appears to be normal in size. Sutures normal. Anterior fontanel closed. No thalassemic phases. Eyes paler present. No cataract, no bite spot. No cave ring, no squint. Fundus normal. Ears normal. Oral cavity paler present. No dental caries. No malalignment of teeth. No cleft lip, no cleft palate. Hands paler present. No thumb anomaly. Nails paler present. No nail abnormalities. Chest is symmetrical in shape. Moves with respiration. No scar sinuses. Abdomen, upper abdomen distended. External genitalia normal. Umbilicus normal. Spine and back normal. Legs no ulcers. Skin no hyperpigmentation. No capillary spots. Systemic examination of abdomen. Child was examined in supine position with the legs flexed at the hip and knee joint. Inspection. Shape of the abdomen is normal. All quadrants moves with the respiration. Umbilicus normal in shape, normal in position. Skin over the abdomen normal. No scars or sinuses. No dilated veins. No visible pulsations. No visible peristalsis. Flanks free. Hernial orifices normal. External genitalia normal. No renal angle fullness. Palpation. Abdomen no warmth, no tenderness. Abdominal girth 40 centimeter. A mass is palpable 2 centimeter below right costal margin along the midclavicular line. Moves with respiration, which is non-tender, with a smooth surface, rounded margins, firm consistency. Not able to insinuate below the right costal margin. Mass is palpable 4 centimeter below the left costal margin towards the umbilicus along the midclavicular line, which is firm in consistency, non-tender, splenic notch felt, moves with respiration, and it is not ballotable, not able to insinuate the finger into the left costal margin. According to Hackett's grading, it's a grade 3 splenomegaly. No other mass palpable in the abdomen. Percussion, dullness over the mass present in the right and left hypochondrium. Liver span 7 centimeter. No free fluid in the abdomen. No puddle sign. Drop space dullness present. Auscultation, normal bowel sounds heard. No renal, hepatic or splenic dopey. No venous hum. Other system examination. Cardiovascular system, first and second heart sounds heard, no murmur. Respiratory system, bilateral air entry present, clear. Normal vesicular breath sounds heard, no added sounds. Work of breathing normal. Central nervous system, tone normal, no focal neurological deficit. Bilateral pupils 2 millimeter, equally reacting to light. Summary. 2 years old male child, second born out of non-consanguineous marriage by spontaneous conception, is a known case of anemia, came for regular blood transfusion, belonging to lower middle socioeconomic class, with the mother having anemia complicating pregnancy, treated with iron sucrose injections. At 6 months of age, child presented with the complaints of fever, cough, cold, and fever and cough and cold for 1 week, associated with the difficulty in breathing for 2 days, and abdominal distension for 1 week, irritability and refusal of eats for 2 days, along with a history of pallor, easy fatigability, and failure to thrive, for which the child is admitted and diagnosed with a transfusion-dependent anemia. And now the child is on regular blood transfusion and oral medications with good compliance. And his parents were found to be carriers. It's a diagnosis. It is a case of transfusion-dependent hemolytic anemia, probably beta thalassemia major.
Good presentation, Raja Saraswati. You said no hemolytic facies. Are you sure? But the picture I had a small suspicion whether hemolytic facies is there. Can you show the face picture which you showed? In this face is not seen. In the other picture, face was seen. Yeah. You think there is no hemolytic facies?
Yes.
Okay, it's a matter of debate. I think it is there. But okay, if there is no hemolytic facies, why do you think there is no hemolytic facies in a case of hemolytic anemia?
Because the child has been transfused adequately.
Okay, so absence means that the child has been transfused adequately. So what is the hemolytic facies? What is it due to?
It is due to the intramedullary hematopoiesis.
Yes, it is due to the excessive hematopoiesis that causes the hemolytic facies. So if the child has been adequately transfused, then you don't expect hemolytic facies. And in the finding, you want to say anything about the tongue?
There was
Specifically, in case of anemias, what you should be saying?
paler. In case of megaloblastic anemia, ball tongue.
Megaloblastic, okay. What deficiency will cause a ball tongue?
Atrophic papillae.
Yeah, atrophic ball tongue is due to what? Folate deficiency. Okay, so you should be telling that the tongue has got its papillae, it is not bald. Similarly, in hands, what you should say in fingers? Negative finding.
Fingers, bifid thumb.
No, I'm talking about the fingers. Fingers. Knuckle hyperpigmentation. There is no knuckle hyperpigmentation. You should say that also.
Okay.
Yes.
Okay. So what do you mean by hemolytic facies? Can you describe the facies?
Yes, ma'am. Frontal bossing with a maxillary prominence, depressed nasal bridge, and prominence of the central incisors. Yes, ma'am.
Don't you think a few of those features are there in this picture? Okay, whatever you described now. Okay. Okay, fine. Sir, over to you, sir.
Yeah, I think not much of questions, ma'am. When you mention mass is palpable, I think when you are very sure that it is liver and spleen, generally I think examiners expect liver is palpable so many centimeters below, and spleen is palpable so many centimeters below. So in a very, very nicely transfused patient, can the liver spleen disappear? Thalassaemic, who is like very well transfused, hemoglobin is always high, like 9-10 grams. Can the liver spleen regress or it is irreversible?
It can regress.
Yes, it can regress. Like how you mentioned, thalassaemic cases may not be there. And ma'am asked about this knuckle hyperpigmentation. What condition will cause it? I'm sure you know.
Vitamin B12 deficiency.
Okay. So in this picture, the picture currently projected, we can see some dental malalignment. What could it be due to? Like protruding.
Intramedullary hematopoiesis.
Oh, we can go to the previous picture. What is he doing?
He's sucking.
Yeah, so can it cause dental?
Yes, sir.
One reason. Yeah, that's one reason.
Yes, sir.
Yes, sir.
Okay. Otherwise, as ma'am said, there are subtle features. I think if you show the nose, that can be a bit depressed and maxilla prominent, etc. Okay. And you mentioned that the child had failure to thrive at the age of 6 months, and now the weight is nearly normal, 0 to -2. So how is it possible? Like what intervention?
Because he's getting regular blood transfusion every 3 to 4 weeks, sir.
So with transfusion, they can regain the normal weight and height. Okay, thank you, ma'am. You can go.
What are the causes of hepatomegaly in thalassemia?
Under transfusion, or if the child has infection with infection like hepatitis, or
No, what is the first cause of hepatomegaly?
Extramedullary hematopoiesis.
Okay, then coincidental infection. Then in late stages,
due
when
to
the child is 10 years old, yeah, due to iron overload. What about splenomegaly? What are the causes of splenomegaly?
First causes extramedullary hematopoiesis, ma'am. Second one is due to hypersplenism, ma'am.
Hypersplenism is a cause of splenomegaly. It is the effect of splenomegaly.
Effect of splenomegaly.
Why I'm asking the cause of splenomegaly. Anything else can cause splenomegaly apart from your extramedullary hematopoiesis in thalassemia?
Any co-infection with
No, in thalassemia per se. Hemolysis can also cause splenomegaly. Okay. Okay. You proceed. How you want to investigate this child?
First of all,
Ma'am, can I ask some questions? Ma'am, can I ask with your
Yeah, sure, Kritika.
Ma'am, actually, they told parents' carrier status in summary, minor defects. In summary, what do you mean by that, Rajesh Saraswati?
Ma'am, in HPLC, both parents were tested for HbA2 status, ma'am. Both are increased, so they were
You have
found to be
not told the diagnosis of the child, but you have not told the diagnosis of the child. But you have told the carrier status of the parents. Which should come first?
Because actually the diagnosis of the child must come first, ma'am. Actually, because of the blood transfusion which is done earlier, parents' carrier status was found at that time, ma'am.
Oh, okay. Did you tell it in the previous history itself?
Yes, ma'am.
Yes, ma'am.
Okay.
Initially,
And what the
starting.
new term for okay. The new term for thalassemia is actually transfusion dependent thalassemia, transfusion independent thalassemia. But you told a new term, transfusion dependent hemolytic anemia, thalassemia major. I think transfusion dependent thalassemia would be sufficient, right?
Okay, ma'am.
You're probably telling beta thalassemia major, but you're very confident about the parents' carrier state. That's what I asked you.
Okay.
You should be very confident about the diagnosis. And also one more point, actually the adequacy of transfusion is determined by the absence of splenomegaly and also the hemolytic phases, and adequacy of chelation is by the absence of hepatomegaly. So your hepatomegaly tells you that the chelation is ineffective, and splenomegaly tells you that the transfusion is insufficient. I mean, sir, please correct me if I'm wrong, ma'am.
Yeah, correct, ma'am. Yeah, very true. But 2-year-old, so iron overload may not be very significant at this moment. The splenomegaly means maybe the transfusion he needs higher hemoglobin to be maintained. It's very difficult practically. Many children will continue to have splenomegaly.
Sorry for the interruption. Thank you. Please proceed.
That's a very valid question. How will you investigate, Dr. Saraswati?
First of all, CBC with complete hemogram with RBC indices, peripheral smear with retic count. In CBC, we look for the hemoglobin, sir. HB will be reduced. In RBC indices, MCV
is the WHO cutoff for anemia?
In
6 months old. In 6 months old,
10.
7 months old.
10.5, ma'am, less than 10.5.
10.5 or 11?
11.
Okay.
Less than 11.
Okay.
11.
Okay, you'll do CBC, then tell some causes of microcytic hypochromic anemias.
Iron deficiency anemia, thalassemia, sideroblastic anemia, and anemia of chronic disease.
Any poisoning?
Lead poisoning.
Okay. Then other investigations.
Then peripheral smear with a retic count. Then HPLC, hemoglobin electrophoresis. Then we can do serum ferritin, LFT, DCT, blood grouping and typing before we have to do. And with regard to complications, for viral markers we have to do. And to look for the iron overload, serum ferritin every 6 months. And For the liver iron overload, liver iron concentration can be seen, or MRI R2 can be done. In case of cardiac iron overload, MRI T2 weighted image can be done. Echo, ECG can also be done. Other investigations with regard to endocrine, oral glucose tolerance test, thyroid function test, and calcium and phosphorus can be done yearly after 10 years of age. Then DEXA scan to look for the bone mineral density can be done.
Okay, you said you will do ferritin level to check for iron overload. You will start doing it right from the time of diagnosis, or when will you start it?
After 6 months.
Oh. Is it the duration or is it the number of transfusion?
After
Number of transfusion, more than 10 transfusion done means we can do 10 transfusions, we
Yes.
can do serum
Yes.
ferritin.
After first 10 transfusions, you will start screening for ferritin. So ferritin above what is taken as iron overload?
1000 nanograms per ml.
Iron overload.
Okay. With the more than 1000, you start initiating the chelation therapy. Okay. And you said you will also check for other abnormalities of iron overload beyond a particular age. Okay. So at what age you should do the MRI? Cardiac and liver MRI generally in a child who is on transfusion and regular chelation?
After 8 to 10 years.
Okay. If they're asymptomatic, at 10 years you will do. Till then, if they're asymptomatic, if they become symptomatic anytime, you will do. Okay, fine. And yeah, you said about diabetes, glucose tolerance test. Is there any issue in diagnosing diabetes in children with thalassemia, which is other than what you normally do in other children? Like, in other words, what about HbA1c? Do you have any concerns about HbA1c level in thalassemic children? Can you diagnose? See, what is the normal cutoff of HbA1c to diagnose diabetes in otherwise healthy child?
More than 6.5.
Okay. What about thalassemia? Is it still the same, or are there any concerns? In anemic child, a cutoff of single cutoff of HbA1c more than 6.5 cannot be taken as an indication of diabetes if there is going to be anemia. If the hemoglobin level is normal, you can still take the same cutoff. But if it is low, if the child is anemic, you cannot take that as a cutoff. You have to rely more on the fasting and postprandial sugar rather than a single HbA1c level. That is one concern.
Okay.
What about LDH?
LDH will be increased.
LDH.
LDH will be increased.
In
hemolytic anemia.
Okay. Sir, you want to ask something, sir?
Just a few, ma'am. So you said CBC at the time of diagnosis. So at 6 months age, hemoglobin was say 3 or 4 grams. So you do a CBC. Surprisingly, it was microcytic hypochromic picture. The WBC was showing 45,000. So in this child, so what could be the reason?
Nucleated RBCs.
Yeah, so it's a spurious leukocytosis. A lot of NRBCs will be in circulation in this anemia, so we can have a false high. So how to correct it? How to know the exact WBC in this patient?
Manual.
Yeah, manually we can correct by doing the peripheral smear. So in such scenario, we always give importance to red cell distribution width. So like how does it help in anemia, microcytic picture, infant?
In case of iron deficiency anemia, the red cell distribution width will be increased, sir.
Okay.
In case of thalassemia, it will be either normal cell.
So thalassemia, all thalassemia, or thalassemia minor, major, intermediate, like
thalassemia trait, it will be normal cell.
thalassemia major or the transfusion dependent variety, it will be increased.
Increased.
Because of the thing. So in hemolytic anemia, we always give importance to reticulocyte count. So how, in what way reticulocyte count in thalassemia is different from other hemolytic conditions like G6PD, hereditary spherocytosis, etc.
Here there will be a relative reticulocytopenia, sir.
Why?
Because of the HB will be very low, but reticulocytes will increase, but not appropriate to the level of anemia, sir.
So roughly in hereditary spherocytes, autoimmune hemolytic anemia, like what is the range of retic you get? Retic count in severe autoimmune or severe HS, hereditary spherocytosis. What will be the level of retic count you get?
More than 7%.
More than 7%.
I normally say 1 to 2%. It's always 7, 10, 15% also. But what would be the reticulocyte range in thalassemia major?
3 to 4%.
Yeah, so 3 to 4. That is the level we see. So why? What is the difference? Is there any specific difference in the pathogenesis? Generally, particular term.
Relative
reticulocytopenia.
Why? In pathogenesis, in the pathogenesis of the disease, like why retics are low? Like there is a difference between the other hemolytic anemia and thalassemia with regarding to the pathogenesis.
Ineffective erythropoiesis.
Correct.
The hemolysis occurs within the marrow itself.
Correct. So even before the retics are formed, it will be lysed within the marrow. That is why the marrow expansion. So the correct term to say is ineffective erythropoiesis. So it's a disease of ineffective erythropoiesis rather than a pure hemolytic anemia like the HS, autoimmune, G6PD, etc. Okay, so you mentioned a lot of tests. Generally, our diagnosis, as ma'am mentioned, not all tests are done. So based on the age, transfusion, received iron chelation status, you have to decide the investigation. DEXA scan, MRI, everything goes to older age. Endocrine will start somewhere in the middle of the first decade, and the initial would be the routine test, as you mentioned. So you missed one investigation which helps in curing the child. What is that investigation?
HLA typing.
Correct. Okay.
HLA matching.
Yeah, true. Okay. Thank you, ma'am. Any other question, ma'am?
No. You tell about the treatment. Investigation's over. So how do you want? You said the child is on some oral drug. What do you think the oral drug will be?
Iron chelators, ma'am.
Okay, which is the oral drug which is being recommended as first line iron chelator?
Deferoxerox, ma'am. The child is 2 years of age, so we can give deferoxerox, ma'am.
Okay, how do you administer it practically?
It available in two forms.
There are two forms, ma'am. Dispersible tablet and film coated tablet, ma'am.
Okay, so how is it given? It's given with hot water. What?
It should be given in a glass of water or juice, ma'am.
Okay, never with hot water. To be given with juice or water, plain water. Okay. And when you give transfusion, what are the precautions you take while you transfuse?
The blood should be obtained 9 to 10 days duration, and it should be leukocyte depleted, leukocyte reduced, gamma irradiated, and CMV free, and it should be obtained after extended grouping and cross matching.
Yes. Okay. And are there any other iron chelators you know of apart from this?
Desferrioxamine and deferriprone. Desferrioxamine can be given either subcutaneously or intravenously. Deferriprone is given orally. The half-life of desferrioxamine is about less than 30 minutes, 20 to 30 minutes. In case of deferriprone, it is 3 to 4 hours, ma'am. In case of deferoxerox, it is around 12 to 14 hours.
Any toxicity of deferoxerox you know of? Because you have started this child on that, so you have to know that.
Yes, ma'am. It can cause renal damage and increase in the liver enzymes, ma'am. So monthly we have to do SGOT, SGPT, urine protein, and RFT, ma'am.
Not just urine protein, urine microalbuminuria you should look for,
Okay, ma'am. Okay, ma'am.
not just the
Urine-
macro protein.
Okay.
You should do microalbuminuria and as well as RFT you have to test. Okay. Any drugs, this is a transfusion dependent thalassemia. If it is going to be non-transfusion dependent, can you use any drug for these patients?
Hydroxyurea, ma'am.
Okay, good. What about transfusion dependent thalassemia? Are there any newer drugs which can be tried maybe at a later age?
Yes, ma'am.
Any newer drugs you know of?
Luspatercept, RBC maturation agent, ma'am. It binds with the TGF beta family of ligands and blocks the signaling pathway involved in the ineffective erythropoiesis, ma'am. That way, it improves the RBC maturation. And
Can it be given in 2-year-old?
No, ma'am. It is approved only in adults, ma'am.
Okay. Any other drug, newer drug?
Gene therapy, ma'am.
No, drug. Okay.
Mini hepcidin.
Enama?
Mini hepcidin, ma'am.
Okay, hepcidin, yeah. How
And,
does this luspatercept, does it replace blood transfusion or how does it help you?
It decreases the blood transfusion frequency, ma'am.
Okay, it reduces the transfusion requirement. It doesn't replace the transfusion. So maybe if you are transfusing once in a month, now you can transfuse once in 1.5 months or something like that. It doesn't replace the transfusion. Okay. What is the curative therapy?
Hematopoietic stem cell transplantation.
Okay. Who are the ideal donors for hematopoietic stem cell transplant?
HLA matched identical sibling, ma'am. HLA matched unrelated donor, then haploidentical donor, ma'am, or umbilical cord blood transplantation can also be done, ma'am.
How effective is haploidentical donor? Actually, the chance of rejection is higher. So, best is HLA matched sibling donor is the best option. If that is not available, you can have MUD. That is, you can have the matched unrelated donor. Okay. Newer drugs. Okay, sir will be able to tell. Sir, over to sir.
Just few questions. You said regarding this precautions during transfusion, leukodepleted, gamma irradiated, CMV negative, and extended grouping matched. So practically, what do you follow in your center? How do you transfuse your thalassemia in your center? Do you do gamma irradiation, leukodepletion, CMV, extended grouping, etc.? Is it possible practically? What do you follow?
We don't follow that, sir.
So what else can what is the minimum thing which we can follow practically in our Indian setting? Minimum one requirement which should be followed.
Depleted RBCs.
Yeah. How can we do that? Like how can we do leukodepletion?
Either by bedside leuko reduction filters or pre-storage filters.
Yeah, so that's very simple. No, filters at 200, 300 rupees. You filter the blood, so that will take care of this most of the problems of recurrent transfusion. Okay. So you said you will start an iron chelation. So you, ma'am, asked about the side effect of deferricerox. You mentioned the other drug is deferriprone. So what is the important side effect of that drug?
Transient agranulocytosis, arthralgia.
So what do we monitor on every visit?
So monthly CBC should be done, sir. Initial 1 year, weekly CBC is recommended, sir.
Yeah, not just HB, we always look at the white cell and the neutrophil percentage also. Okay, in current era, what are the indications for doing splenectomy? Do you do splenectomy regularly?
No, sir. In case of hypersplenism, when the transfusion requirement is more than 250 ml per kg per year, we'll be doing splenectomy, sir.
Okay, still can we try to postpone by doing some other intervention?
by giving vaccinations.
No, postpone the sense, can you avoid splenectomy and do something else to bring down the spleen size?
Hypertransfusion can be done.
Yeah, correct. Yeah, we can give a short trial of hypertransfusion. The spleen size is getting small, we can try and retain the spleen. So what is the problem in removing the spleen? So it's a single time surgery. So, but why do you want to postpone? What are the complications?
Infection with the capsulated organisms.
Okay, one.
Then there will be a
And it causes
thrombocytosis,
thrombocytosis.
which
Pulmonary
will lead to
hypertension
pulmonary
will be
hypertension.
Yeah, pulmonary hypertension is important late complication. We try and avoid splenectomy. Okay. So the child is 2 years old. So coming to your visit, so you did all of these. What any extra important thing you would counsel the parents apart from treating this child, transfusing, chelating, monitoring the growth, vaccination? Any important counseling you give the parent?
Regarding the regular blood transfusion.
Okay, treatment of that child is taken care in all aspects. Another important, they said this is the second child. The child is already 2 years old now. So what will happen? Like next, both parents are in front of you.
Genetic counseling for the further pregnancy.
Yeah, how do you counsel?
In case for prenatal testing with chorionic villus sampling or amniocentesis can be done.
So can counsel the parent. So I think you can demonstrate. You think I am the parent, you counsel me.
The counseling will be given regarding the mode of inheritance and the chance.
No, you counsel. I mean, you counsel, you demonstrate, a live demonstration. Think that I am the parent, you counsel. So I am already having a child who is getting transfusion. I'm asking you, is there a chance of recurrence? How can I prevent?
There is a chance of 25% in the next pregnancy, sir.
Okay. So how can I prevent? I don't want such situation again.
Sir?
How to prevent in my family? I don't want similar situation again. So what? How should I proceed? So the wife is pregnant now. UPT has come positive. So what should I do next?
So next, around 11 to 13 weeks, we can go for the chorionic villus sampling, sir.
Okay. The sample
from this, the DNA of the extracted from the fetal cells can be diagnosed for the genetic mutations, sir.
Okay. So now the mutation has come positive. It is homozygous for beta thalassemia major disease. So how will you counsel them?
Then we have to ask for the parents' decision, sir. We have to tell about the disease nature of the disease, cause complications and treatment and all. And we have to ask them to take the decision regarding continuing the pregnancy or terminating it.
Okay, usually in our scenario, see, you are the doctor, you are like a god, so you have to tell me what should I do. I don't have any idea. So you say something about the gene test mutation, I don't understand. Should I continue or not? Please give me a one-word answer. Give your opinion rather. You give your opinion. You cannot ask me to do, but what will be your opinion as a doctor? Should I continue or not?
Then it will be solely based on the parents' decision.
I am the parent. I am giving you an option. Please give me an you give a suggestion to me. So I am illiterate. I don't know gene mutation nothing. So you give me your opinion. So you are not giving me an order. You give me an opinion. Will you continue or no?
Can terminate.
Okay. So termination is an option. I think as a doctor, scientifically, you should say it's disease with a lot of morbidity and other stuff. You already have a patient. You have a patient in front of you. 100%, the next child is also going to have the disease as per the genetic report. So medically, termination is an option. So it is an indication where MTP can be done. So my opinion is yes, you can proceed. You can. I said you can, but you can proceed. Somebody asks you an opinion, you can proceed. That's what you can. Thank you. Okay, ma'am, that's from my side. Ma'am, any other questions?
Okay, sir. Ma'am, any other questions from you, ma'am?
No, no.
Dilip, ma'am?
Good
Okay,
presentation,
sir.
Raja Saraswati,
Yes, yes.
and good
Yes, ma'am.
answering, Ramya.
Yeah.
Thank you,
Both
ma'am.
of them did very well. They answered almost all of your questions, ma'am.
Yeah.
Naresh, sir, your concluding remarks, please, sir. Naresh, sir?
Yeah.
Sir.
Good evening, every one of you. I am Dr. Naresh, Associate Professor, Department of Pediatrics, Thuthukudi Medical College. I am very much honored to be there at this platform. I think my students has done very well, but both the faculties has given us a very good information regarding the thalassemia and they have covered all the. Sir? I don't get you. Hello? Hello, am I audible?
Yes. Okay,
Yes, sir.
Yes.
Sir, am I audible?
Audible, sir.
Yes, sir. Yes, sir.
You are
Very well
audible,
audible.
sir.
Yeah, well. So I think both the faculty has done a good job and they have really covered all the parts of the discussion. They are complete. They have gone to the differential diagnosis of the transfusible anemia, and they have taken to the in-depth discussion about all the possible management of this thalassemia. The newer management like gene therapy and all the other parts have been discussed. The chelation therapy has been discussed in detail. So I think I am very much very thankful for the team IAP for helping our students to present in this forum. Thank you, no. Thank you, sir.
Thank you so much, sir. You should be very proud of your students. They did so well, sir.
Thank you so much.
Thank you so much, Sridevi ma'am and Vinod sir. It was a very useful discussion. Vinod sir, can we have your presentation now, sir? Please share.
Sure, ma'am. Do we have time or we can?
Sir, we have 10 more minutes, sir.
Okay, maybe I think most of the things were discussed.
Yeah.
I don't think I have
You can
anything.
just add some things.
Yeah, I think I'll just go through the slides. I think I hope it's visible, ma'am.
Okay, sir.
As
So we have
everybody-
all the time.
So hemoglobin in structure, it has 2 alpha and 2 beta. Thalassemia can be alpha or beta depending on the mutation. In India, we predominantly see beta thalassemia. That's why in the entire session, we never discussed about alpha thalassemias. Alpha, if all 4 genes are deleted, it will be a hydrops fetalis leading to intrauterine death. But if it is a HBH, where 3 genes are mutated, even we have 1 or 2 patients with HBH, they will behave like a thalassemia intermedia or a non-transfusion dependent thalassemia. So it may be missed in the usual electrophoresis. You should think of alpha thalassemia if you suspect thalassemia, but HB electrophoresis is not showing. So this is purely biochemistry, we can omit, but here the last right corner of this image, we can see the typical adult pattern of electrophoresis. Electrophoresis more than 1 year of age should show the adult pattern, that is predominant HbA, more than 95% adult hemoglobin. Fetal hemoglobin should be less than 1. A2 should be somewhere between 2.5 to 3.5. At birth, we have nearly 80% fetal. So 80% fetal at birth is purely normal. Gradually, it falls down to reach the adult value by only at 1 year of age. So in thalassemia major, this adult transition does not happen because beta gene is mutated. So even at 1 year of age, if you have a predominant HbF with anemia hepatosplenomegaly, that is how we diagnose thalassemia major. So thalassemia minor, as the presenter mentioned, HbA, HbF will remain normal. This is a slight increase in the HbA2. Say anything more than 3.5, usually we will have 4%, 5% A2 level. Rest all will be normal. That is how we diagnose thalassemia carrier state. It's very, very important to diagnose carrier because that is where the prevention plays a role. So this is what I mentioned. Like at birth, it is predominantly alpha 2, gamma 2. That is, this 80% of the hemoglobin at birth is alpha 2 and delta. This is delta 2. That is the fetal hemoglobin. By around 1 year, the adult hemoglobin reaches the mature level. So as again, Kritika mentioned, terminology slightly changed. TDT, NTDT, transfusion dependent thalassemia. NTDT is non-transfusion dependent thalassemia. Or to equate the previous terminologies, thalassemia major is currently called transfusion dependent thalassemia, where we have all the beta thalassemia major, severe E beta, and non-deletional HBH, the type of alpha, where we require a lifelong transfusion. There is another category of thalassemia where they require only intermittent transfusion. You can have patients who come once in 2-3 months or even twice a year to get transfusion with a big spleen. Those are NTDTs or previously called as thalassemia intermedia. The thalassemia trait or thalassemia minor are the totally asymptomatic parents of thal major. So as mentioned regarding the pathophysiology, it is mainly the ineffective erythropoiesis. Ineffective erythropoiesis where within the bone marrow, the erythroid series cells gets precipitated and die because of the excess of alpha chains. So alpha beta mismatch where the excess alpha globin chain precipitates within the red cell precursors leading to ineffective erythropoiesis is the predominant pathophysiology. The membrane damage and hemolysis, which is the predominant pathophysiology in the other conditions like G6PD, etc., does not happen in thal major. That is why we have a relatively low retic count and the bone marrow expansion, etc. So this long-standing anemia, we have to transfuse, which leads to iron overloading, and if you don't chelate, leads to cardiac death within the second or third decade of life. So apart from that, they can have the skeletal hypermetabolic changes because of the bone marrow expansion. So if you don't transfuse, this is the typical phases which we discussed: depressed nasal bridge, maxillary prominence, dental malocclusion, frontal prominence. All these are the full-blown hemolytic phases which we don't see nowadays because of widespread transfusion availability. Massive hepatosplenomegaly, as we know, regular blood transfusion. Generally, thalassemia major presents from 6 months to 2 years. First 6 months, they are asymptomatic because it is the fetal hemoglobin which is predominant at birth to that 6 months of age. After 6 months, when the alpha 2 beta 2 has to pick up, it does not happen. Only then the symptoms manifest. Like progressive pallor, jaundice, hepatosplenomegaly with incidental fever, that is how we usually diagnose. Failure to thrive, feeding problem, irritability due to anemia, bouts of fever due to the hypermetabolic state because of anemia, and repeated transfusion is how we diagnose. If you don't manage properly, late features, that thalassemic phases, bone deformities, non-healing leg ulcers, extramedullary hematopoiesis. I have a patient who came with paraplegia at the age of 25. It was a thalassemia with a paraspinal extramedullary hematopoiesis causing nerve root compression leading to paraplegia. So this is a very, very late complication if you don't manage properly. Iron overload, which will open up a separate range of complications which we have to monitor side by side. Thal intermedia, they manifest at a later age. They can live without transfusion, but they will have growth and developmental problems, and they do have a significant extramedullary hematopoiesis, leg ulcers, and they can have a thrombotic complication like pulmonary hypertension, vascular thrombosis, which is a very unusual complication in thal major, but it is a common complication in thal intermedia. Thal intermedia also can have iron overload because due to the anemia, chronic anemia, iron absorption is also increased. So as discussed, anemia, low hemoglobin, low MCV, low MCH, increased WBC because of the NRBCs in circulation are the initial diagnostic findings. Microcytic hypochromic RBCs, anisopoikilocytes, target cells, NRBCs. This is an NRBC which is seen in the circulation. Target cells, as you can see, the central dot, which is not usually seen in a red cell. These are all features of thalassemia in the peripheral smear. Electrophoresis, as I discussed, now this is the normal electrophoresis, 97 adult, A2 2.8. This is a thalassemia carrier where adult is 94, fetal is 0.6, both are normal, but A2 is 5.3. A subtle A2 increase is thal carrier. Thal major is predominant F. F peak persisting beyond 6 months, we have to consider thalassemia. Inheritance, very important, autosomal recessive, both look handsome, asymptomatic, no anemia, no liver spleen, but they have one silent carrier gene. When they get married, 25% chance that the child can have thal major. 25% doesn't mean only 1 out of 4 children will be affected. If their fate is bad, all 4 children can have thal major. I have a patient who had 3 consecutive pregnancies, all had thalassemia major. Subsequently, 4th pregnancy by prenatal diagnosis, it was excluded and had a healthy child. So 25% means it is purely statistical meaning, but every pregnancy has equal chance of having thal major and a carrier state and a normal. So all pregnancies need to be tested prenatally in a carrier couple. So coming to management, as we discussed, transfusion, chelation, to do spilectomy or not, how to monitor the complication and take them for a bone marrow transplant setting, and the NTDT is a separate way of managing it that is not to be discussed here. So when to transfuse, once you have a thalassemia, electrophoresis need not put them everybody on regular transfusion. HB should fall less than 7 on 2 separate occasions, more than 2 weeks apart, after correcting your B12, folate, etc. So if the child is repeatedly having a drop in HB less than 7, okay, then you label them as thal major, put them on regular transfusion. Otherwise, if the child is having facial growth changes, hemolytic phases, poor growth, huge liver, spleen, fracture, all these are indications. Irrespective of hemoglobin, you put them on regular transfusion. Leukodepletion is a must. Radiation, everything, we can forget CMV, we can forget extended grouping also may not be possible, but leukodepletion is a must. Pre-storage or bedside as discussed. This will prevent febrile non-hemolytic transfusion reaction. After a few transfusion, every transfusion will have a reaction. To prevent that, start with LDPC, leukodepleted packed cell, right from beginning. In future, if you want to transplant the patient, again, leukodepletion helps, because if you give the plain blood, the patient will develop antibodies against all HLA antigens, and the patient may reject all sort of donor in future. Again, CMV infection is a major problem, which the incidence will be decreased by giving the LDPC. So what is the HB target? I think we didn't discuss throughout the discussion. Pre-transfusion hemoglobin should be 9 to 10.5. At the day of transfusion, hemoglobin should be 9 to 10.5. In general, in iron deficiency, other condition, if you see a hemoglobin of say 9.5, we will not transfuse, we send them home on oral supplement, etc., or come after 2 weeks. But in thalassemia, hemoglobin is 9.5, you transfuse the same day. You don't allow them to fall below 9, because if it goes below 9, extramedullary hematopoiesis kicks in, and they will have hepatosplenomegaly, etc. Again, don't be overzealous to keep a very high target. That will increase your chance of iron overload. So 9 to 10.5, 0.5 here and there is okay, but don't go very high or very low. This will help us having a normal growth, normal activity, suppress the bone marrow expansion, and the iron overload is also relatively well balanced. So this is the bedside filter. So this is the blood bag. This is the normal IV set. In between, you collect this filter, or in the blood bank itself. While after collection of blood, it passes through a filter, and then it is stored in another bag. This is pre-storage leukoreduction. So one side on iron overload. So it is a non-transferent bound iron which will be deposited in all organs from head to toe. Main is the hypogonadotropic hypogonadism, hypothyroid, hypoparathyroid, iron overload in the heart, which is the major killer, liver deposition in future leading to cirrhosis, liver cancer, etc. Pancreatic deposition causing early onset diabetes in this patient, hypogonadism leading to the fertility issues. That is the like in general predominant iron overload complications. So as mentioned, ferritin is the easily available test. Ideally, we should target less than 1000, but practically may be very difficult, but at least less than 2500. Most of the complications can be prevented because of the iron overload. Liver iron concentration, in olden days, biopsy were done. Nowadays, we don't do biopsy to monitor the liver iron because we have a better techniques like MRI. As mentioned, T2 star MRI for the cardiac iron can be done in older children. Iron chelators discussed already. 3 iron chelators, 1 parenteral, 2 oral. Preferable to start with the deferripirox, once daily preparation. Deferriprone we have to give thrice a day. We should start at least after 5 years of age. Deferripirox nearly 2 years, 1.5 to 2 years we can start. If we cannot manage with 2 oral iron chelators, we should go ahead with the parenteral to prevent the long-term complications. When to start, again discussed. Roughly around 2 years, almost everybody will be on oral iron chelation. By the time the ferritin will be more than 1000, this is one indication. Transfusion iron load more than 120 ml per kg, around 10-15 transfusions. LIC, which we don't do nowadays, in olden days, liver iron concentration was one of the criteria. Splenectomy, again, I asked a question. We try and avoid splenectomy. You give a slightly higher rate of transfusion that may cause spleen to shrink and subsequent transfusion requirement may go down. But if it is beyond the limit, definitely splenectomy is warranted. Vaccination should be remembered. Post-splenectomy, aspirin should be remembered. Aspirin, penicillin prophylaxis, pre-splenectomy vaccination, we should not forget. Complications, again, complications may be related to overload, maybe because of transfusion, maybe because of chelators, endocrine, pregnancy. All these are special scenarios to be done. Cardiac overload leads to myocardiac failure, dilated cardiomyopathy, cardiac failure, etc. So liver, again, iron overload is one way of destroying the liver. Another angle, Hepatitis B, C may come in put together. They may lead to fibrosis. I think gonadal complication, endocrine, we have discussed already. Bone, again, osteoporosis, petrosis, and recurrent fractures. So we have to maintain a good calcium, vitamin D level in patients with thalassemia transfusion. Psychosocial is a total story of itself. They have a lot of psychosocial problems at home, at school, financial effects, another social stigma, which we have to balance throughout the treatment. Preventable, yes, we have to prevent it. At least if you have a thal child, the next child should never have thalassemia by prenatal diagnosis. At a larger scale, governmental level, mass screening or screening all antenatal women. Now government is focusing on tribal areas where thalassemia is prevalent by screening all pregnant women with electrophoresis. If the woman is a carrier, screen the husband. If both the husband wife both are carriers, you do a prenatal so that even the first child with thalassemia can be prevented in affected families. So that is how we have to proceed. If one husband or wife, one is normal, one is carrier, then there is no need for antenatal testing because the chance is 0. If only both are carriers, only then we have to proceed with chorionic villus sampling. One slide about bone marrow transplant. Yes, it's a highly curative treatment. All we need to do is do it early at a very good shape with a perfect match. As ma'am mentioned, perfect match will definitely improve the outcome. And earlier, before you heavily transfuse, before the liver, heart function has started to affect, if you do it in a younger age, somewhere around 2 to 5 years is the ideal age to do transplant, where we can have up to 95% survival. As the child grows old and old with multiple transfusion and other complication, the survival goes down to 70% by the time of adulthood. But again, half match is also increasingly done with the improvement in outcome with the advances in transplant available nowadays. And a few words about the recent advances that have been discussed. Gene therapy, yes, it's still under research across the world. Practically in India, we don't have yet. Luspatercept is one drug, again, or at least for older thalassemics who are not transplanted. Some subcutaneous injection once in 3 weeks. It's very easy to give. May delay the transfusion. It doesn't make one transfusion free. Roughly 1/3 transfusion requirement may go down. That not in everybody, a small proportion. Beyond 12 weeks, if there is no, give it over a period of time. If there is no response, you stop the drug. If there is a response, yes, you can continue. Currently, cost is an issue where government supports are available. Patients are getting it. In gene therapy, there are FDA approved drugs, gene therapy available, but not in the reach of our Indian population yet. Thank you. Thank you.
Thank you so much, Vinod sir. It was so crisp and very clear. Srinivasan sir, your concluding remarks, Professor sir. Okay, sir has clapped. So overall, it was a fantastic presentation and well discussed. Thank you so much, Sridevi ma'am. Thank you so much, Vinod sir, for that excellent discussion. And Ramya and Rajesh Saraswati, you both did very well. And congratulations to the mentors. And Arunachalam sir, your concluding remarks, sir. HOD of Pediatrics in Thoothukudi. Arunachalam sir. I think sir is not available. If there are no further questions, shall we close the discussion?
Yes.
Thank you. Thank you,
Good night,
sir.
all of you.
Good
Thank
night.
you.
Good night. Good night, sir, ma'am. Good
You
night,
all.
ma'am.
Thank you, IAPTNSC. Thank you all.
Thank you, ma'am. Thank you for your
Well done,
graceful
Thank
Madam
you, Vinod
Sri,
sir.
and
Thank you, ma'am.
thank you.
Thank you. Thank you so much. Thank you so much.
Thank you, Kritika.
Bye, ma'am. Good night.